Welcome, boys and girls. We had our latest trainers talk, and I have a very special guest. I have Dr. Bodor, who has been in Napa since 1995. He is on the staff of the Queen of the Valley and St. Helena hospitals. He has been affiliated with the Departments of Neurological Surgery at UCSF, Physical Medicine and Rehabilitation, UC Davis, and he's on the board for the Neuromuscular and Electrodiagnostic Medicine and the American Institute of Ultrasound and Medicine. His CV, I was like reading his CV. It's long. I'm here in his clinic here in Napa, and we're having this conversation. I'm so excited to sit down with you.
Pleasure to have you here, Donovan.
The first thing I kind of wanted to start off is what inspired you to become a doctor, especially in the sports and pain management side of things?
That's a great question. My father was a doctor, and my grandfather was a farmer. And I liked having a connection with my community and being able to do something tangible, something good. I also like training. I like working out.
Yeah.
When I was in junior high and early high school, I was in track and field. And back then they said that if you lifted weights, you're going to get muscle bound and you wouldn't be able to run fast. But I didn't listen to them. I lifted weights and I was really skinny, but I lifted weights and it made me even faster and stronger. So I went against the grain and I set a number of records in the 600 meters and the hurdles and we had a decathlon, a little mini decathlon. So I had a number of achievements there, and I felt it was all because I took a very rational approach to training.
Yeah.
And so I've always been interested in training. And then when I went to college, I majored in biology and anthropology. So I was very interested in human performance and how we adapt to our environment. And then when I went to med school, I thought I was going to be an orthopedic surgeon. But with orthopedic surgery, you're mostly interested in the bones.
Yes.
And the bones are not moving. And I really like the parts that are moving.
Yeah.
So it's like if you were in the automobile business, are you interested in the motor or are you more interested in the frame or the body, the structure of the body? So I like the motor.
Yeah.
And so I like the muscles and I like the nerves. And I also like the bones and so forth. But what I was really interested in was performance. So I wasn't sure what field I was going to go into. Then I found this field of rehabilitation medicine, which is really centered around muscle. We're also interested in nerves, but it's centered around muscle. But then there's also on the other end of the muscle is a tendon. And then from the tendon, it goes to the bone, to the joint, and then to movement.
Yeah.
So this is why I chose this particular field.
Yeah.
And I do research that expands all these fields. I am published in orthopedic surgery. I'm published in the journal Muscle and Nerve, in the American Journal of Sports Medicine. And then I got into the healing aspect, just like you. You have found, I'm sure, in your career, this is the central part of your career, how training can help people's injuries.
Yes.
And it's still a real mystery to us. Why does this happen? Why can somebody have back pain for 20 or 30 years and then they go train and it goes away?
Yes.
And that's the magic. And that's the same magic that I'm pursuing, just like you.
Yeah.
And I'm pursuing it from the standpoint of looking into the body using my ultrasound machine that I have right here. It's the Philips IU-22. It's really the 747 of 747 being the airplane.
Yeah.
of ultrasound machines. It came out in 2003, and when it came out, it was like, I remember when the 747 came out, it was like, wow, can something be that big and that amazing? And this allows me to look inside the body at a higher resolution for surface things than MRI.
Wow.
So an MRI can look down to 1/3 of a millimeter. With this, we can go down to 1/10 or 1/20 of a millimeter.
Wow.
And so we can find little micro tears and things in the body. And the other thing that this gives us that the MRI doesn't is the ability to interact with the patient while we're examining that particular structure. So I can actually look at something on the screen and actually just push on it with a little probe and say, does this hurt or does that hurt? And so we really have to be in tune with our bodies and listen. And there's this kind of feeling in modern medicine that we're not smart, and the only thing that's smart are computers, and they're going to tell us what's wrong with us. But really, a good physical exam and very careful exam using ultrasound can reveal what particular structure is sore, whether it's just the upper third of the teres minor tendon, the rotator cuff, or it's the lower part of the infraspinatus tendon, that kind of thing.
Yeah.
And we can pinpoint with millimeter accuracy where a problem might be coming from. And unless you can find that specific problem, you may not have a chance at healing it. So I always want to try all the approaches that you're doing,
Yeah.
because so many things can heal if the patient or client gets the right sleep, the right exercise, and it's really interesting to try to figure out what the right exercise is, and it's a lifelong pursuit. Why is it that chronic tendon injuries, counterintuitively, they respond to heavy loading? That's eccentric training, heavy loading. That was so counterintuitive when it first came out. And so there's all these different aspects of training that we know can reverse a chronic degenerative condition and stimulate healing, stimulate protein synthesis in not just our muscles that we see on the outside, but on the inside of our bodies. There's stuff happening, not just on the outside. But sometimes those mechanisms, despite our best efforts, they don't quite complete the healing process. And that's where I'm focusing on my ultrasound, try to find that little area. And then what I'll do is I'll inject right into that little area with your own body's healing cells. And these cells, they work best, whether they're platelets or bone marrow cells or fat cells, they work best where they can't get to naturally.
Yeah.
So one of our best places is, for instance, the disc, the intervertebral disc. For muscles and so on, muscles are full of blood. If you ever have a deeper gash or something, it'll bleed like crazy. But a disc, if you were to cut on a disc, nothing would happen. There's no blood in there.
Yes.
So that is an area that's an avascular, means very limited blood supply. And for something like that, if we can deliver cells into that a little micro tear in there, we can affect the repair. So these are very basic, essential, ancient principles. I mean, the most ancient principles of surgery are, you get a thorn in you, you get a gash, you got to remove it, you got to kind of pull it out.
Yes.
So removing an abscess or removing something that's stuck inside you is the first principle of surgery. The second principle of surgery is closing the gap, closing the hole. And that was done thousands of years ago with stitches. They learned how to stitch thousands of years ago. And if you close the wound, it's going to heal faster than if you leave it open. And the same thing on a microscopic level. If I take these platelets, which are like little nanosurgeons, that's their role. Like if you cut yourself shaving in the morning or whatever, you'll have a little bleeding, and then that bleeding will turn into scab. The scab will eventually fall off, and underneath it, you'll see a little wound that gets smaller and smaller and smaller. Well, that healing cascade starts with the platelets, which are the first ones to form the clot. And they have little arms on them. And those arms actually have little muscles in them that have actin and myosin, the same muscle proteins that are in our muscles. They're actually able to pull things together and hold them tight, close them, and then cells will migrate across and you'll heal a little micro tear. And that's how we can heal like 80% of chronic disc pain patients. Wow. Patients who have bona fide chronic disc pain. I'm not talking about spinal stenosis, which are pinched nerves, but I'm talking about just bona fide disc-related pain that usually hurts with sitting, bending, and that kind of pain. I thought in my lifetime we'd never have a cure for it. But the only way we're going to cure it is by losing weight, by exercising, by sleeping, which we should do anyway.
Yes.
But if it doesn't go away, then there could still be a tear, which no matter how hard you try, you might not be able to heal. And then we can try to heal those little gaps. And so that's been a real focus of my research and my work for the last 10 years.
Yeah, so you definitely. I mean, we had a little conversation about it a couple of weeks ago, and you're a leader in that space. I think PRP and
yes.
What makes you decide if you're using the platelets versus the bone versus the fat? Like, how does that decision get made?
Yeah, the platelets are our go-to, our first choice.
Yeah.
And especially for, like I said, the discs, avascular structures. That would be the meniscus in the knee. If there's a little tear in the meniscus, you want to catch it early. You don't want it to progress. You don't want it to degenerate and flatten out, and then you're going to have increased loading of the tibia and the femur. And you're going to develop arthritis. But you want to catch that meniscus and preserve it. So for many meniscus tears, if we put the platelets in, you're going to be able to close that gap. So my first choice are platelets.
Yeah.
Now, for arthritis, which means loss of cartilage, they are effective, and they are able to recruit stem cells to the area. They're able to increase healing and so on, and decrease the pain. And that's been shown in many randomized controlled trials. Now, there have been also trials that have been negative. But if you look carefully at those trials, the dose might have been too low or something like that. But if the trials are done right, those trials show that with PRP, you will have arthritis will feel better for many, many people. Um, but if it's really bone-on-bone arthritis or more advanced arthritis, or maybe a young athlete like in their 40s or something like that, and they are too young to have a knee replacement, there might be a little bit of arthritis. That's where we would use the cells, using the bone marrow or the fat. That's where we would use those. And those work differently. I was talking about the platelets working like little nanosurgeons, but these other cells, we thought that they would go in and just kind of replace the other cells.
Yes.
But they're not actually replacing the cells, but they're helping those cells. So they will exchange their mitochondria, which are the little energy factories in the cells. They'll actually exchange and give it to those poor cells that are the bone-on-bone, in the bone-on-bone areas. They're depleted. They're just been like workers have been working hard and trying to like maintain the cartilage, and they're just depleted of energy. And then these new cells come in and say, hey, have some of my mitochondria. Here, have some of this, have some of that. And all of a sudden, these cells that are there are rejuvenated. That's our best estimate of how this is working, is by exchange of mitochondria and other cellular components are exchanged with those cells. So that's how I would choose.
That's interesting. You kind of said it in your explanation that your mindset. It's very clear that your mindset is trying to find less invasive ways of improving the health of the patient or the client. And where did that mindset first, when did you start to think, hey, this is really a possibility of going this route of, because a lot of times most people think of, oh, I tweaked my knee or I tweaked my ankle, or I tweaked my shoulder, I'm going to need to do surgery. What kind of got your mindset to be, maybe there's another way, maybe there's a way that doesn't require you to go under the knife.
Yeah. Sure.
Yeah.
That also goes back to high school. I remember that when I would feel sick or feel not so great, I would just go out and exercise and I'd feel better. So that was one place.
Yeah.
And another one, I did have an injury running track in 9th grade, and I tore my posterior cruciate ligament. Everybody's heard of the anterior cruciate ligament. The posterior cruciate ligament, it's one of the two key ligaments in the knee. And I saw how successfully that could be rehabilitated, even though to this day I have 8 millimeters of laxity. So my tibia will move back 9 millimeters relative to my femur. And by maintaining my quad, keeping it strong, I was able to have no issues. I go skiing, I do everything. And so I realized that the right type of exercise could make up for some laxity here and there. It can stabilize joints and having the right kind of strength. So that was pretty much when I realized it. And the other time that I realized it was when I was in my surgery rotations. As an intern, I did a year of surgery, and I saw that we spent 99% of our energy in the operating room.
Yeah.
And then when we went to the clinic in the afternoon, you start at 7:30 in the morning, and then you operate till 1 or 2. And then you all the intense work is done. And then you go and relax in the clinic and you see your patients. And at 2 o'clock in the afternoon, I saw that my chief residents, the guys who were my superiors, they really weren't that concentrated on trying to figure out non-surgical ways of healing. They would just kind of give a very simple or straightforward answer that was not thought through very much. Mm-hmm. So I thought, well, there's a whole space here that somebody could work on, somebody who understands medical problems, surgical problems, that could just develop these things. So that's was my curiosity was piqued that way, and I thought, well, I could make a career out of this. So that's kind of what got me started on that.
That's interesting. So you, I know recently you're working on a research when it comes to the ACL. Is that correct?
Absolutely, yes.
And I would love to hear more about what you're seeing currently in that research, and
Absolutely.
what you're finding. Tell me more about that research you guys are doing.
Absolutely. So if you wouldn't mind, maybe you can hand that model over there.
Yeah, that's
There's
great.
a knee model right there, and I can demonstrate to everyone. So yeah, of course, the anterior cruciate ligament, there we go. The anterior cruciate ligament is right here in the middle of the knee. You can see it right here. There's the anterior cruciate ligament, and then we go in the back, and there's a posterior cruciate ligament. So these two ligaments, they're the primary internal stabilizers of the knee. And as you all have probably heard, when you hear of an athlete blowing out his knee, that usually involves an anterior cruciate ligament injury. And that ligament, once it's torn, will destabilize, will result in the knee being very unstable. And we always thought that the ACL had a very limited capability of healing itself, and that maybe 1 out of 100 patients might get lucky and it might just scar down, usually in the proximal part, the upper part, it might scar down and so forth. But recently, studies done in Scandinavia, paper by Kanun and so forth, they found that up to 25% of them will heal.
Oh, wow.
That's a much higher number. And now, if you ask an orthopedic surgeon in Scandinavia in a panel, in an orthopedic surgery meeting in Scandinavia, you ask them, well, what type of operation would you want for your acute ACL injury? So, oh no, I would just rehab it.
Yeah.
I would rehab it and see if I'm one of the 25% that heals.
Yeah.
Because the advantage with healing your own is because, first of all, there's a little nerve that sits on top of the ACL, and that nerve sends signal to your brain to tell you where your knee is in space. So it's an extra sensor, proprioceptive sensor. And the other thing is that the tension of that ACL is perfect, when we have it.
Yeah.
When we've grown with it, when it's made for you, when we've grown with it. And it's not just like a round hot dog shaped structure. It's kind of like a little bit of a fan. It's like a little triangular and so on.
Gotcha.
And there's two bundles, an anterior and a posterior bundle, an anterior medial and a posterior lateral bundle. And so the doing the graft, you can make it strong. You can take a piece of your patellar tendon, and transplant it and make it strong, put screws in it or whatever. And so sure, if I tried to tackle you, it would be strong.
Yes.
But would it be precise?
Yeah.
And would it allow your knee to move really precisely in space and allow you to be able to pivot at a moment's notice? And is your knee going to be as precise, as high performing as before? It might be strong. So that's the question. And so what we've done, we were surprised that we were able to get 9 out of 10 of these to heal.
Wow.
And that were called complete ACL tears.
Yeah.
And there are different levels of completeness. As you can be like 99% complete, which means there's 1% fibers left.
Yeah.
And I'm demonstrating here, like just for instance, like this could be, there's only 1 fiber left, but that, as long as that 1 fiber is there, it allows these guys to kind of come closer together.
Gotcha.
And if you think of the Golden Gate Bridge, like how did they get a span across that huge 2-mile space?
Exactly.
You first have to get a wire across. You just get 1 wire across, and then you get another wire across, and then you get cables.
Yep.
And so the same thing. If you have that 1 cable left, then these are aligned. And even if you don't have that single cable left, as long as the fibers are within 1 centimeter of each other, the cells can cross the gap.
Gotcha.
Because the ACL has its own little sheath that it sits in. It's like a hot dog. It's got a casing. It has its own casing, and that casing is going to allow injected cells that we inject to stay right in that gap and start crossing the gap. So we've been able to get 9 out of 10 of these to heal that were really considered to be complete. And at least one of the bundles would heal. But in our most recent case, a 17-year-old, we got both bundles to heal. And that's not even the goal of surgery. With surgery now, it's single bundle repair is the gold standard.
Gotcha.
A double bundle repair was tried, but it was felt to be too complicated, and the outcomes weren't any different. Just doing both, because you're not tensioning every single fiber in that collagen. You're not tensioning it optimally. I mean, if you wanted to tension optimally, like tuning a guitar, you have to each string would have to be tuned and perfectly tightened. But you don't. You just put in 1 big screw, 1 big on either end, and you just have a gross, reconstruction of that. But that's why I think it's really nice to try to get it to grow back, where you're going to have natural retensioning of each of the fibers.
What is the timeline difference between somebody with the surgical route
versus the interventional route?
Interventional route. What are you guys seeing?
So the interventional route. So as far as return to single leg squat is one of the criteria you try to aim for.
Yeah.
ACL. We were able to get people to do a single leg squat if they're athletic and not overweight in 6 weeks.
Yeah. Wow.
6 weeks. So So actually, one of my patients, he's in South Lake Tahoe. He won't mind me using his name. His name's Oliver Starr, and he raises wolves and trains wolves for movies and stuff.
Okay. Wow.
So he lives up in the mountains in a log cabin with several wolves. And so he injured his leg in February several years ago, and someone else injured their leg same day, and they were competing against each other who's faster, and he definitely beat out the guy who had the surgery.
Yeah.
And so, so yeah, at 6 weeks you're able to get that single leg squat. At 3 to 6 months, I still want them to be careful and conservative because
Yeah.
the full healing doesn't happen until a year. And when we get an MRI at 6 months, you notice that there's 50% improvement of density. It's not as dense as before, but at 1 year, then it reaches its full density. So we're really trying to be careful with it. But you can do everything. Certainly, you also don't sacrifice any other part of your body, like which,
Yeah.
if you're getting a graft, a patellar tendon graft, and so on, you're going to sacrifice that. And there's some people do get pain in the central 1/3 of their patellar tendon from the graft site.
Yeah.
And that can be an issue for some people.
I mean, I also wonder too, with doing that method of being less invasive, it also, because I've worked with some people who are returning from, they've had a ACL surgery. There's a point at where they're just not even that mobile of a person. They're on crutches. So their ability to be active with their rest of their body is very restrictive.
I allow weight bearing from day one. So
Yeah.
we allow weight bearing.
Wow.
We just want to avoid terminal extension. But what's interesting in many of these patients, when they come in, they might have 1 or 2 strands left, and your ACL, when you go to terminal extension, when you really go all the way straighten out your leg, the ACL is actually tensions up at that point.
Yeah.
And if they have 1 or 2 strands left, they feel that. They starts to hurt when they start to get to that pull. So there's a natural feedback telling their brain, like, don't go there. So as long as it's really important that that natural feedback remain. I don't want them taking anti-inflammatories or Tylenol or anything. I want them to know exactly when you feel that tension. That means you don't go past that point. So you have that natural limitation based on the pain and so forth. So I let them go out and do everything. If they want to get into some more dynamic sports, like go back to skiing at 6 months or something, I want them to wear a brace, like a DonJoy carbon fiber brace or something. So we let them have that. Now we've done knee function scores at 1 year, and we're comparing our outcomes to UC Davis sports medicine surgical outcomes, because we're doing a study through UC Davis. And we found that our scores were, UC Davis surgery was 88, 89, 90, 91, and we were 90, 91, 92, 93. So both were really good. They were almost 100%, but the scores were 80, very comparable. Our scores were 1 or 2 points higher, which is considered to be statistically insignificant difference, but so comparable. But the real question is going to be, what about 5 years down the line? Who's going to have less arthritis?
Yeah.
Is it going to be the more precise knee, which I like to say it's more precise? We don't have proof that it's more precise, but I think we will be able to prove it. There are new 3-dimensional X-ray imaging equipment. There is new equipment being developed by the University of Pittsburgh, and the Steadman Hawkins Clinic in Vail, Colorado has it. They got it from Pittsburgh, because it was the same people developing it. And using that equipment, we'll be able to determine who has a more precise knee, and down the line, who's going to have less arthritis. Because 50% of ACL reconstructed knees go on to have some arthritis down the line, which is unfortunate. So that's our goal, is to have a more precise, more higher performing knee, but also less arthritis, lower rate of arthritis down the line.
You just opened up another door there, arthritis. One of the things, and this might be a little more of a selfish question. So I have my clientele, for the most part, I have some people in their 30s. I do work with teenagers occasionally for like getting them ready for sporting seasons, college athletes also. But I would say 80% of the people I'm seeing are probably 45, 50 and up. My oldest client is 91. So usually at some point I'm noticing that, they're running into, I would say, out of 10 or 15% of those clients, they're running into probably some arthritis situations, either in their hands, like a thumb. One of our mutual friends who's a chef, I think, has a little bit some in his thumb. from being, working in the restaurant side of things, and then also um, skier where he's starting to feel some discomfort in his knee, but I think he's been so blessed because of his work ethic and stuff like that. It's is not a big issue. But I just wonder, what do you see? What when somebody coming in and they feel like they're having some arthritis pain, how do you normally address that?
Well, I try to see if it's a hip or if it's a knee. I want to see if there's a labrum tear or a meniscus tear because I want to fix those. So the meniscus provides a nice support, a cushion. It cradles the femur
Yeah,
on the tibia. So if you didn't have a meniscus, then you have high point pressure because you have this curved surface on a flat surface, and the curved surface is going to have point pressure
yeah,
on the flat surface. But the meniscus cradles that, so it redistributes the forces. So I want to try to see if I can get that meniscus to heal. And if they have something called a root tear, that should be reconstructed surgically, arthroscopically, because we can't get the platelets to do
yeah,
that much of an approximation. But with small tears, they can heal, and we have evidence for that. And with the hip labrum is such a key to the hip joint. So the hip joint has to maintain nice lubrication,
yeah.
and the lubrication is, um, is kept in place with the hip labrum. Labrum meaning lips. So like just our lips keep our food in our mouth, the labrum keeps the fluid inside the joint. If the labrum is torn, it'll leak out.
Oh, yeah.
So we try to get that labrum to heal, and we've had patients with 5, 10 years of pain, and maybe minor or very early arthritis or something. But when we get that labrum to seal with our platelet injection, then they feel much better. And it happened to me. I had pain for 10 years. My fellow injected it because I finally did something more extreme and it really was hurting more. And then all the pain went away, the pain that was recent and the pain from 10 years ago
Oh,
prior.
wow.
And I can go in a big gear up a hill for like an hour and it doesn't hurt.
Oh, wow.
So
Um, you know,
so that's what I would say.
yeah,
But then there are others who have more arthritis, like actual loss of cartilage. In that case, I would say we can try the cellular treatments and so on. And that we're still have a long way to go with those cellular treatments. The latest is that we actually are not focused so much on the surface of the area that's getting worn out,
hmm,
but the underlying bone. So it's really everybody's talking about subchondral bone now. The cartilage and the subchondral, meaning sub below the cartilage,
yeah,
subchondral bone is really key to try to restore its strength. Like if we think about the road outside of our office here, it's getting worn out. There's asphalt thinning. Yes, you can focus on the surface, but you also have to think about what's underneath that layer of gravel, whatever. How solid is that? Is it rolling a little bit?
oh, yeah,
Is are heavy trucks, causing it to deform a little bit, and so on. So now with our injections of the bone marrow cells, when we take bone marrow from the iliac crest, the back,
yeah,
which is a non-moving part, which never wears out, we borrow some cells from there and inject them. We'll actually inject them not just in the joint space, but in the subchondral bone, in the bone there, to kind of make that bone super strong again. And if that bone doesn't deform, then those other cells have a chance to kind of, grow back a little bit. And or even if they don't grow back, the cartilage doesn't grow back, as long as the bone is strong
yeah.
and you get bone on bone, then it doesn't hurt. But if the bone is not strong and it's depleted, then you get bone on bone, then it's like ouch, ouch, ouch.
Yeah.
But bone on bone can be tolerated just fine if it's solid. If it's solid as a rock.
Hmm. That makes a lot of sense because I have a client who's 77, and he has great bone density and bone strength, and his knee has been um, when he had an examination, and he's on bone, but he doesn't have any discomfort because his quads are really strong, his legs are really strong.
And his bone is probably like
Yeah,
a diamond, like
exactly.
a carbon fiber or diamond,
Exactly.
hardness.
So
Yeah.
so that kind of that makes sense on that part. Um, I'm really enjoying this. I don't want to take too much of your time, but one of the questions I did want to think about is you kind of just mentioned it there about the future. Like, what are you seeing in terms of medicine or your field that you're getting excited about that is probably in the next 5 years to where you think things will go? Maybe if you really went out 15, 20 years, where do you think things will go with the power of rehabilitation and also medicine.
Yeah, that's a great question. I think, well, one thing that where we're going is earlier recognition of the problem, and it starts with not taking anti-inflammatories for an injury.
Yeah.
And there was a great study that came out in Science and Translational Medicine last year out of Montreal, where the researchers were surprised. They were pain researchers.
Yeah.
And so the pain researchers are always focused at pains in the brain, and that if you have pain for a long time, it's going to develop in your brain and you're going to be stuck with it, even if you heal the injury.
Wow.
And there's some truth to that, but I keep finding that that's really not that true.
Yeah.
As much as they think it is. And they tested rats, and they injured their tails. The tail is an extension of the spine.
Yep.
And there's those vertebrae in the tail. So they injured their tail, and they gave one group of rats anti-inflammatories, Advil, non-steroidals, and so on. Yep. And the other group, none. And so they were expecting that the group that got the anti-inflammatories would have less chronic pain, but it was the other way around.
Oh,
the group that did not take the anti-inflammatories had less chronic pain. And then they thought, well, this is interesting. Then they went into the UK Biobank, that's United Kingdom health system, and they looked at 9 million patient records, computers-wise, and they were able to find that, yeah, the patients who took anti-inflammatories for their acute back pain were more likely to have chronic pain. So one thing that we're going to find is that we're going to find that our younger patients are going to get the right treatment early, and they're not going to be taking anti-inflammatories for their pain and then continue to play on that injured knee.
Yeah.
And so that's one area where we're going to be ahead of the curve in those people. And then we're going to again, we're working on the subchondral bone. That's where we're going to be injecting underneath there to make that stronger. Well, once we can improve that, then we might be able to get cartilage to resurface better on the inside. And that's quite elusive, but there have been some studies. One out of Brazil, it was Americans and Brazilians together. They just injected something very simple, which is dextrose, which is a sugar.
Yeah.
And the dextrose and glucose are the same thing.
Yeah.
5% or 15% dextrose solution was injected into the joints. It's called prolotherapy, and we used to kind of look down on prolotherapy. It was kind of the domain of doctors that hadn't done residencies and specialized, and they were just kind of kicked out of their program. And what do? They can't practice in a hospital, so they set up shop at a little strip mall, and they do prolotherapy. Yes, exactly. But that turns out this stuff really is working for some things. Yeah. And for carpal tunnel and things like that, it seems to be helping it. But the little bit of sugar was shown to actually resurface the joint, the cartilage a little bit. And that was done based on looking at scopes. They put cameras in, and looked at scopes, and it was a smaller barrier. The barrier became smaller. Mm-hmm. So that was interesting. That study hasn't been replicated because you have to scope people. That's pretty invasive to just find out, hey, is it actually getting smaller? And if people are feeling good, they're playing soccer again, like, do you want to get your knee scoped again? No. So, but these people were motivated enough to get scoped again. They did see that the cartilage had regrown a little bit. So I'm optimistic that if they were able to demonstrate with dextrose, which is a very basic substance. Yeah. And why would that work? Well, cells seem to respond well to a happy environment, and when there's dextrose around, that means there are no bacteria around, because bacteria will eat up dextrose. So bacteria will lower dextrose. Like one of the ways where we diagnose meningitis is where we get spinal fluid, we do a spinal tap, and if the sugar is low, then that means there must be bacteria eating it up. And cells probably sense when there's nice sugar around, well, sugar, that means there can't be bacteria, which means they can kind of relax, and they don't have to be kind of in this protective mode. So the bottom line with that study was that they were able to demonstrate that there was an improvement of the bare area. The bare area was smaller with just dextrose. So if that could be shown, then hopefully with some of these cellular treatments that we're developing, and we may get the right formula, may be able to get just the right formula to get more things to regrow. Yeah. And the other thing is that definitely the loading pattern is really important. How they're loading, what they're doing for training, what their quad balance is, what their gastroc soleus balances, medial gastroc, lateral gastroc, all those things, they're all going to affect it to some degree. And just the right amount of loading is really important, because loading after these procedures is really important to get the cells to increase their collagen production. Because if they're loaded a little bit,
Yep.
they increase their collagen production. They found at the University of Pittsburgh that these vertical loads are better than the shear loads, sideways loads. The vertical loads are better. And then the question is pulse better than continuous? And yeah, pulse is a little better than continuous. So we're going to find more about loading and so on. And they're doing this work at Pittsburgh in the lab. But there's also just feedback from your patients, your clients you're exploring this all the time too, and then you might find out, well, this seems to work and that doesn't work, and that's where we're all going to be communicating, and we get translation of knowledge from one field to the other, and you go from the whole person level to the cell level and vice versa.
Yeah.
So we are noticing that we think of ourselves as rest and digest and fight or flight mode, like you can relax and you can grow, or you could be all stressed. But cells are in that same paradigm. They live in that same paradigm, rest and digest versus. And so there's a lot we're learning, and I'm hoping that, yeah, in a few years we'll be able to program the cells to try to grow and sideways and so on. But it's a gradual process. It's not like it's going to happen like all of a sudden. It's very gradual. It's like our cell phones. I mean, there was a big, when cell phones came out, it was like all of a sudden the iPhone. But every year they get a little better now. But it's not like next year we're going to have like something amazing. It's just slightly better than last year. And we still had Uber 5 years ago, and we have Uber next year, and it's not that different, but it just keeps evolving a little bit.
Yeah, totally. That makes a lot of sense. Do you, before we wrap up, do you have any questions for me or anything like that?
Tell me about some of your some magic transformations, because I will learn from your examples and translate that to what I'm doing.
Yeah, so I would say the transformations I'm seeing, and some of this is with different clients and things like that, is one thing I'm obviously noticing is this helps as I've gotten older too, of what is the prep for the body, like even as my clients, I've been working with certain clients for over 12, 15 years. Mm-hmm. And what's cool is you get this longitudinal kind of data of seeing where they were before when they first started and where they're at, and the strength level and maintaining their fitness level of where we even started, like even when they're younger, it's more always about consistency. Mm-hmm. And it's not as much about intensity. Mm-hmm. Especially when they're getting over 45. Mm-hmm. So I've seen it where 30-year-olds, 20-year-olds, they can get away with doing 2 to 3 pretty strong workouts and they're good. Mm-hmm. And things like that. And what I'm noticing is that what's more important for my clients that are over 45, 50 is, as they get older, is to focus on precise movements, diversity of movement, but doing a little bit of something every day. And even if the intensity level is, so say it's, when you're 20, 30, you're doing 80, 90%, maybe you're going really hard and you're going to be really sore for a day or two. What's more important for as you're in that 50 plus is to go mainly 50 to 70%. Mm-hmm. Have some diversity where maybe once a week you really push it. And then maybe you build in the programming to do more mobility, more restorative stuff the day after. Mm-hmm. And those things, what ends up happening, I have 6-year-olds who are pressing, they can press 80, 90 pounds with dumbbells. They can do box jumps that are 3 feet high. It's what also happens, it almost becomes a level of practice. Mm-hmm. Like they become better at the skill of movement by doing that consistent movement pattern. And so because of that, they put themselves in scenarios where they can still ski they can play tennis,
Mm-hmm.
they can do things with their grandkids or their, um, and I think one of the things that when I was at Salage, uh, one of the things that happened was our company's been very good at working with members where as they get stronger, our program starts to get stronger.
Mm-hmm.
And something that was interesting, we did a kind of informal study of seeing that the members that were 50 to 70 were stronger than the people who were 20 to 30.
Wow,
And
that's
so
pretty
it was
cool.
it was interesting. Some of it is because the 20 to 30 they're working, they can only come to the gym, or
Mm-hmm.
they can only come to classes and do things for themselves maybe 2.5 hours a week. The 57-year-old, they're slightly semi-retired or really
Yeah.
can control their schedule. They're doing anywhere from 5 to 10 hours,
Mm-hmm.
and their stamina it just crushes.
Mm-hmm.
And just seeing that that's possible, I think is really remarkable, because when working in hotels, you get guests that are coming in and they see these people in the class and like, how old are you?
Mm-hmm.
when they see them moving. So I would say the consistency over anything as you get older is more important. If you just do a little bit every day, you'll be surprised how strong you still
Mm-hmm.
get in the improvement in your movement.
Mm-hmm. Yeah, that makes sense.
Yeah. Um,
Yeah.
yeah. So it's really cool to see that. I think other like big thing is it's playing with nervous like plyometrics.
How
And
about have you been able to get rid of back pain in some patients? And
yes, usually what I've found that when uh, usually like a simple test I'll do for clients, if they say, or somebody comes in and say, they've been having back pain. Well, first I'll ask, is it localized in a spot, or
mm-hmm.
does it feel like, is it on the right side, left side? Where is
Mm-hmm.
the discomfort coming from? And if somebody who semi works out regularly, then I'm like most likely a soft tissue, especially if it's a general area.
Mm-hmm.
And so usually uh, I kind of have a sequence, and I don't know if this happens to you, where you've been doing something for so long that sometimes you can just see the patient, and I can tell it's like, oh, your left glute, or your left glute medius
Yeah.
is tight. We just need to put a lacrosse ball there and kind of rub that spot. It will create a little bit of flow in
Mm-hmm.
the attachment point,
Mm-hmm.
and just that will start to relieve some of the
Oh,
pressure.
yes.
Or I think another one is the psoas muscle,
Mm-hmm.
because of the attachment points into the bottom of the lumbar and
Mm-hmm.
the spine there. Sometimes getting that released, if somebody, often happens when somebody's been traveling.
Mm-hmm.
They come back from a trip, they drive from San Francisco airport, they've been in the car. The next day they come in and they try to do their gym workout. And they're like, something's not right. And it's often because they've been sitting for a long
Yeah.
time. And just by releasing their glutes,
Mm-hmm.
they feel 90% better.
Ah, fantastic.
So
Yeah.
like often that will get 90% of it. And then there is some other things of working on learning how to use your glutes, or learning how to use your
Mm-hmm.
hamstrings correctly when you pick things up,
Mm-hmm.
and developing those muscles around it, so that and your core and everything, so that it protects it and reduces that pain.
Excellent. Those
Yeah.
are great insights.
Yeah. So how do people, if they're hearing this and they're like, I have something and
Sure.
I want to
Well,
come
you could
into your
just
clinic.
Google my name, Marko Bodor, Marko Bodor, Bodor, Bodor Clinic. Call the phone number there, 707-255-5454, and we'll get you in.
Awesome. Love it. And I really appreciate, sitting down and having time, and maybe we'll do a part two and just come check in on the latest things on some of these research articles.
Absolutely.
I appreciate it.
It's a pleasure to meet you.
Pleasure
Take
to
care.
meet you too.
Bye-bye.
Bye.